Daniel Bugembe, a fourth-year medical student at Kampala International University. I'm presenting a case on peritonitis. Can you go to the next slide, please? Yeah, this is this is the biodata. As we can all see, we had a 64-year-old male. His tribe was a Munyankole. He's a farmer from Butayonza village. The son was the next of kin. He's married and is a primary 7 graduate. He was the nearest medical center. It was Kayebe Medical Center. And he was referred from a clinic to our facility. I clocked this patient at 7 p.m. on that date, the 10th of October, 2022. Our presenting complaint were fever for the 2 days, abdominal pain for 3 days, and vomiting for 3 days, as we can all see. The history of the presenting complaints were Mr. Philip was well until 3 days ago, prior to admission to the clinic, when he suddenly got severe abdominal pain that was sharp, consistent, and stabbing, radiating to the back, which was aggravated by movement, breathing, and coughing, and could be relieved by lying on his back and not eating, associated with abdominal distension. When asking him, he says he was vomiting green vomiters. He also reported satiety. Let's go to the next slide. He also reported satiety, early satiety, nausea, and occasionally had poor appetite for food for the period of those 3 days. He reported to have failed to pass stool and flutters for the 3 days. However, on his referral note, which we got from him, the clinician who attended him in the clinic, he said he had passed some black stools after he was given enema. Then he also reports history of epigastric pain for the last 5 years, which he said had always been relieved when he gets some tablets from the peripheral clinic. But unfortunately, he couldn't identify the name of the tablets, and he didn't have them at the moment. He had also reported use of some herbs in the management of the epigastric pain. Next slide. Yeah, he also reported to have failed pass urine for the 3 days, but he was able to do so after he was catheterized. He says the urine was yellow and smelly. He reports there was no pain on urination. That is after they had passed the catheter. He says after they had passed the catheter, he passed urine and then they removed it. And he said after that, there was no urgency and there was no pain on micturition. The next day, he developed a low-grade intermittent fever, which was not associated with chills. He reports no dizziness, no broad vision, and there was no loss of consciousness. There were no headaches and no ear pains. Doctor, that is part of the history of the presenting complaints. I beg to go to the review of other systems.
Yes, please continue.
On the review of other systems, the respiratory system, Philip reported a non-productive cough with no difficulty in breathing, and there was no chest pain. On the musculoskeletal system, there was no joint stiffness. He reports no joint pains and no joint swellings. On the cardiovascular system, Philip reported easy fatigability with palpitations, with no any other problems. I don't know whether I reported it well, but That is what he reported. Can you go to another slide? On the history, the past surgical history, he reports to have no history of any surgery performed on him. There was no history of blood transfusion, no burns, and no history of trauma leading to maybe fractures or other things. On the family social history, he's the 5th born in a family of 10. And he says the 4 of them died of a natural death. He's a married man to 1 wife with 6 children, all alive. He reports no history of a genetic disease in their family. He says that he used to be a chronic alcoholic for 5 years back, since he used to work in a local brewery company and would take about 3 mugs of local brew a day. About this, he told me that every time he would go for work, he would take, it was something like he takes a bottle of water. So he would take, since it was the water around. He also used to smoke tobacco because his father used to grow it. He, however, says to have stopped both 5 years back. I tried to ask him about the reasons as why he stopped. He told me he changed the religion. He became born again. That's the word he used. He became born again and he was saved, so he would not take alcohol and smoke tobacco, since it's not allowed in their religion, the current religion. He reports no history of chronic illnesses in their family, like hypertension and diabetes. The past medical history, he reports that he has had about 5 hospital admissions his entire life, and the last one being about 6 years back when he suffered from malaria. His serostatus was unknown at the moment when I cracked him. My summary was Bitakaire, a 64-year-old male who presented with fever, abdominal pain, distension, and vomiting, who came in as a referral from a peripheral clinic with no known chronic illnesses and no known serostatus.
Excellent, excellent. So at the end of the history, what's your probable diagnosis? At the end of the history, what do you think most probably patient is having?
Doctor, at the end of the history, I thought the patient would be having a peritonitis, either secondary to a perforation due to the history of the peptic ulcer disease.
Very good. Brilliant. Brilliant answer. Next.
Then I also thought the patient, sense of those palpitations and the easy fatigability, we can also have a GI bleeding somewhere. Actually, it can also lead to peritonitis. And we had also talked about the black stools in the history. So I thought we might be having an upper GI bleeding somewhere, but it can also be linked
upper GI bleeding from where? He had ulcer, right? You told PUD he had, peptic ulcers he had. Those ulcers were bleeding up ulcers. That caused melena. Nothing else.
Yes.
Upper GI bleeding, nothing but the bleeding from these peptic ulcers, either gastric ulcers or the duodenal ulcers were bleeding little by little. That was causing the melena. Clear? So again, because of anemia, if he's having anemic because of chronic bleeding, he would be anemic. Even anemia will cause this easy fatigability and the palpitation. It's a hyperdynamic state. You understand?
Yes, doctor.
Please note down, when anemia, chronic GI bleed can result in anemia, which will manifest as easy fatigability and palpitation. See, you only found out the reason also, correct? Very good. Good. Genial. So next, examination.
Yes, doctor. Thank you so much, doctor.
No, you are really brilliant.
Thank you. On the physical examination, on the general exam, we had an elderly sick-looking man lying spine in bed, moderately wasted. He was conscious and calm, not in distress. He was alert, oriented in time and place. He was febrile on touch, with no jaundice, with severe conjunctival and palmar pallor, with mild cyanosis, with no lymphadenopathies, grade 1 edema, and moderate dehydration. On the cardiovascular system exam, the capillary fill was 10 seconds. The radial pulse was present, weak with a low volume. The pulse rate was 165 beats per minute, and there was no radio delay. The blood pressure was 110/60 millimeters of mercury. The neck vessels were not extended, and the jugular venous pressure was not increased. The precordium was active, and the chest was normal shape and symmetry with no surgical or therapeutic scars. The apex beat was palpable at the 5th intercostal space on the left midclavicular line. There were no heaves, no thrills, and heart sounds 1 and 2 are heard with no added sounds. On the respiratory system exam, the chest was of normal shape, size, and symmetry. The patient had a shallow but fast breaths with a respiratory rate of 22 beats per minute and saturation pressure of oxygen at 95% on room air. The trachea was centrally located with normal bilateral air entry. It was resonant on percussion. The breath sounds were heard all over lung fields with no abnormal sounds heard. On the abdominal exam, the abdomen was distended and not moving with respiration. There were no therapeutic, no surgical scars. The umbilicus was everted. There was generalized tenderness on palpation and muscle guarding with rebound tenderness. The bowel sounds were not heard on auscultation. The percussion note was dull, and there was no shifting dullness, no fluid thrills. The dictal exam revealed normal anal sphincters, and the rectum contained dark black stools on the examining finger. The prostate was palpable, non-tender, rubbly, and normal in size.
Next slide, please.
On the CNS exam, he was lethargic, but fully conscious and well-oriented in time, place, and person, with no neck stiffness and negative Canning sign. The GCS score scale was 15 out of 15, with eye opening 4, visual response 5, and motor response 6. The cranial nerves were not examined. Doctor, being honest, on the CNS exam, I didn't do much. This is the little I did. Then finally, my clinical impression was peritonitis, secondary to a gut perforation, and upper GI bleeding. And that is all I had, doctor.
A patient has come with just a distended abdomen. What do you think? Possible causes? This, what I mean to say, in simple words, what are the causes for distension of abdomen? There are seven causes. I'll make it easy for you. Please try first, then I'll give you a mnemonic.
Okay, we can have flutters.
Very good.
As a cause of distension. We can have fluid, ascitic fluid.
Oh, you know it already.
Or something.
Very good.
But I know about 3 of them.
7 Fs. 7. You please write it down and please share with your friends. Okay?
Yes, doctor.
7 Fs. Most common cause for distension of abdomen is fat. Correct? Many of us are obese, and that's the most common cause. Fat. Second thing is fluid. What is fluid inside the abdomen called? Ascites. Many of us are alcoholics. So because of alcoholic liver disease, they will have cirrhosis and ascites. So second cause is fluid. Third most common is the fetus, pregnancy. Any lady comes with distension of reproductive age group, lady comes with distension of abdomen, you should suspect pregnancy. Fourth thing is, like you said, flatus, gaseous distension. Because of intestinal obstruction, there is gaseous distension is there. Fifth thing is feces. Again, because of intestinal obstruction, there is feces accumulated in the bowels. That's what causes distension. Sixth and seventh. Sixth is full bladder. What is that? Full bladder. If the bladder is distended, okay, it will be seen as a lower abdominal fullness, distension. Okay, some people may not be with in a 65 70-year-old gentleman may have prostatic hyperplasia and may cause urinary retention and may present with distended bladder. Okay, so full bladder. Seventh is fatal mass. Fatal mass, that is any organomegaly, any malignancy. Okay, any mass in the abdomen, like ovarian mass or liver mass or any renal mass, they can also present as abdominal distension. Why it is not moving with respiration? Abdomen is not moving with respiration. Why?
Doctor, I think it's because there is tension on the abdominal muscles, and we know the abdominal muscles play a part in the respiration. But here they are distended, so there is a tension onto them.
More than that, Daniel, so peritonitis means inflammation of the peritoneum. So anywhere inflammation is there, for example, you have a pus in your finger. If you touch it, what happens? It pains, right? If you touch anywhere, any wound on your body, what happens? It pains, it hurts. So now entire peritoneum is inflamed, it's injured. So when we take breath, okay, when we breathe, what happens? All these visceral organs will touch, okay, the peritoneum, and it causes more pain. You understanding? That's why it's a defensive mechanism. Body tries to avoid pain by not moving. If you take a deep breath, all the viscera will move. Instead, if we take shallow breath, then viscera will not move. So there will be no abdominal pain. So in peritonitis, to prevent pain, they will not have shallow breathing. That's why they'll have tachypnea and shallow breathing, so that the abdomen doesn't move, so that the pain also will be less. Is it clear? That's called silent abdomen. Please note it down. When the abdomen, along with the respiration, usually our abdomen moves. If the abdomen is not moving, that is typically seen in peritonitis. It's called silent abdomen. Okay. And what is this guarding and rigidity? You have mentioned about muscle guarding, and there is another word called rigidity. What are those? You know?
Yeah, doctor, this is guarding is when you try to palpate on the abdomen, the patient tries to fight back, to resist from.
Exactly. Fantastic.
To resist from.
So voluntary muscle contraction to avoid pain is called guarding. Whereas involuntary muscle spasm is called rigidity. Please make it note. Voluntary, when the clinician's hands comes towards your abdomen, he voluntarily contracts his muscles, abdominal rectus muscles. It is called guarding. Whereas in Uganda, you have seen police people holding the guards, stone pelters. They're throwing stones, and these police people, what they do? Okay, they show the guards, correct? They have a shield. They have the shield with them. Wherever the stone is coming, they'll just hold it, try to avoid the stone, with the shields. You correct? Agree with me?
Yes, yes,
That's
doctor.
called guarding. Whereas rigidity means it's an involuntary muscle contraction or muscle spasm due to some inflammation. So here what has happened means what the patient is having is rigidity because of the peritonitis, inflammation of the peritoneum. Even the rectus muscles have gone into spasm because of the irritation of the muscles. All the muscles have gone into state of spasm. You know what is spasm? Like when we run and all, we get muscle cash, in our calf muscles, spasm. Like that, all our abdominal muscles go into contraction. Then it's called rigidity. The entire abdomen become tight, so hard and so tight. It's called rigidity. Clear?
Yes, doctor.
Why bowel sounds are not heard on auscultation? Tell me. Why bowel sounds are absent in this patient?
Yeah, doctor, I think the reason as why bowel sounds are not heard, there is less movement of the bowel.
Why? What's that called? Condition called?
The condition is called
if my limbs are not moving. What is that called? If my limbs are not moving, I'm not able to move my limbs. What is that called? Paralysis. Similarly, if our gut doesn't move, the intestine doesn't move, what is that called?
That is paralytic areas. If the gut is not moving.
Paralytic ileus, because of the inflammatory fluids, even the gut also has gone into a spasm. So it's called paralytic ileus. Clear? So on percussion, note is dull. Why it's dull? Usually the abdomen is resonant, but here the percussion note was dull. Why?
Doctor, it's because of the peritonitis.
Oh, no. Peritonitis itself will not cause dull note. What's happening? Because of peritonitis, what happens? When you get dull note in abdomen?
It's because in peritonitis, we have a fluid in the abdomen.
Yeah, same. Excessive fluid secretion happens. Okay. So fluid, because of fluid accumulation, there is dull note. Okay. Good.
Yes, doctor.
So, okay, rest all is fine. There is a melena also present. Okay, fine. Digital rectal examination you have done. Excellent. Next slide, please. Okay, so now your diagnosis is peritonitis because of peptic ulcer perforation, and he's also having anemia because of upper GI bleeding. Okay, how do you manage this case? How do you manage this case?
Doctor, the management of
perforation with anemia.
We are going to first do the baseline investigations in the line of management, and we shall need to do a CBC first of all.
Okay.
It will give us the HB estimation, and it will give us a picture of peritonitis in terms of leukocytosis and
very good
and the other serines. Then after the CBC, we shall need to do a plain abdominal X-ray.
Excellent.
It will give us the location it will give us a definitive diagnosis of the location of the perforation in case it exists. And I think the positive, we shall see air below the diaphragm on a plain chest X-ray.
Okay.
Then after that, in the management, we shall have to do the resuscitation.
Oh, very good.
Of the patient before theater, because you get perforation. Basically, the management will be surgery, an abdominal explorative laparotomy. That is the commonest in our countries.
Yeah. Same here. Same in our country. Our diet.
So we shall do an abdominal explorative laparotomy to locate the perforation and rectify it.
So there is a perforation. When you do the laparotomy, you find an ulcer or perforated ulcer in duodenum, first part of duodenum. What do you do then? Dr. Daniel is a consultant surgeon in near Kampala, and the only surgeon available, for the service. And patient is having severe peritonitis, and he has resuscitated him. Now he's ready for surgery. So Daniel has confidently opened the abdomen, and he found a 1 centimeter big perforation in the first part of duodenum. What will he do?
Okay, I don't know the exact name of that.
That's okay. That's how you tell me idea what you are going to do. You are going to close the perforation. How? Either by suturing it, primary closure by suturing it, or else you'll put a patch, something to cover. Tire punctures. You have a 4-wheeler or 2-wheeler with you.
I have
vehicle, 2-wheeler vehicle or 4-wheeler car with you. Have you seen how the car tires are puncture repaired? How do they repair? You haven't seen. Okay. In omentum, omentum?
Yes, doctor.
Omentum, they will cover it over the perforation and then they will suture it all around. It's called omentoplasty. What's that? Omentoplasty. If the perforation is very small, you can primarily close it. Okay. If it is very big, then you can cover it with a omentum. Omentum is greater omentum is very free. The edges are freely lying, so you can just move it wherever you want and put it over the perforation and just close it. That's the treatment for. And after that, what you'll do? You'll give a thorough abdominal wash, because lot of bacterial and chemical peritonitis is there. To get rid of that, you'll give a thorough lavage with normal saline. Minimum 5 to 6 liters of normal saline lavage you will give, and then you'll close the abdomen in layers.
Warm saline, right?
Yeah, warm saline. Very good. Warm saline wash you will give, and you will close it. Okay, that's the surgery for duodenal perforation. And for anemia, what you can do?
Doctor, for the anemia, we shall transfuse.
Okay, blood transfusion. If it's severe anemia, if it's less than 8 and all hemoglobin, then you can directly transfuse PRBC.
Then good enough, the pathology, the etiology is collected. That means if it's closed, that means we shall have a better prognosis.
Simple as that. Okay, now there is no more ulcer, no more bleeding. So unlikely to progress with anemia. So once the etiology is treated, then automatically his blood amount will increase in the body. Correct?
Hello.
So
I have a question.
Yeah.
So, doctor, like if we find the clinical signs of perforation, is it must we do abdominal X-ray, or those clinical signs?
See, I told you, there is a clinical test. A good question. I wanted to tell about this, but I don't know to what extent you will understand that. Clinically, you can diagnose perforation with a test. It's called, just like Daniel mentioned, in X-ray, the sign is gas under the diaphragm. So you can clinically, without X-ray, you are in a very remote area where there is not even X-rays available. So you can clinically assess it by obliteration of liver dullness. You percuss, over the chest wall and abdomen, So usually between the 5th intercostal space and 9th intercostal space, there will be dull note because of the presence of liver. Correct. But when you percuss, if you get resonant note in between, resonant note in the place of liver, then that means there is obliteration of liver dullness. What has happened? Air has gone and covered in between the diaphragm and the liver. There is air accumulation of air between the diaphragm and the liver. That will give you a resonant note. So this is a clinical sign from which you can elicit there is a pneumoperitoneum. Daniel, you understood what I showed?
Yes, doctor.
Because of some visceral perforation, maybe duodenum, maybe ileum, whatever. Because of some perforation, whatever is there inside the colon or the gut, what is there? Usually gas. Okay, that has leaked out and present in the abdomen. Usually, they will come into the they will be accumulated just below the diaphragm. Because low density area. Okay, low density area. So when you percuss over that, just in the area of diaphragm, you will get a which note? Normally, you should get what is there just beneath the diaphragm. Usually, normally, what is there on the right side, just below the diaphragm? What is there? Liver. Liver is there. Correct. So if you percuss on liver, you will get dull note.
Dull note.
Dull note. But now you are not getting dull note. Instead, you are getting resonant note. When you will get resonant note? Whenever there is air or some gas is collected, you will get resonant. Okay. So in the place of liver, if you get resonant note, then that means that there is obliteration of liver dullness, which is suggestive of perforation. Abdul, is it clear now? Abdul? Okay. So your rightly said, Daniel, mainly management includes investigations and then treatment. So investigations you do clinical blood and mainly X-ray of the abdomen. Okay, where you get gas under the diaphragm classically. Then you do laparotomy. Once you resuscitate the patient, then you do the laparotomy and do closure of the perforation. That's a treatment, and that's how you can get rid of peritonitis also. Peritonitis was secondary to perforation. So once you close the perforation and with the good antibiotic coverage, peritonitis can be subsided. Okay, you need to give a good antibiotic, including all the gram positive, gram negative, and anaerobic bacteria, cephalosporins, aminoglycosides, and metronidazole. All these 3 antibiotics should be given, and proper analgesics. Okay, and make sure that his systemic involvement doesn't progress. See, now already patient may be in renal failure. For that you need to treat, and patient may be having pleural effusion. For that you need to take care. Okay, so he may require ICU management with proper monitoring. ICU care is better for such patients because of hypotension, because of sepsis, peritonitis and sepsis. They may succumb anytime. Septic shock. They will go into septic shock, so they can succumb anytime. So you need to be very careful and vigilant in these kind of cases, especially when you are in peripheral centers. When there are no facilities available, please refer them to higher centers where there are all the ICU facilities, operative facilities are available. Okay, don't neglect these kind of peritonitis cases. These are really dangerous, and morbidity and mortality is very high.